Good morning. Thank you, Galit, for the kind introduction. Thanks to everyone to be here this morning to listen to us. So as Galit said, I'm professor at the University of Montreal in Quebec, in Canada. We are talking this morning about the NOL, and I'm going to talk about the NOL-Guided Analgesia in the daily practice. We are going to talk about some research that we have done at Maisonneuve-Rosemont Hospital, but we are going also to talk about the use of NOL in the clinical daily practice. Few disclosures. Galit said that I'm part of the Scientific Advisory Board of Medasense, so you know that. For the last 15 or 17 years of my life, I've been working on pain sensitization after surgery, meaning that we look at how an acute pain can become a chronic pain, and we look at all the mechanisms that underline the fact that an acute phenomenon can induce what we call PPSP, it's persistent post-surgical pain. We know that high level of pain during the surgery, high level of trauma, surgical trauma, and a lack of good analgesia during the surgery will lead to sensitization of the central nervous system, but also the peripheral nervous system. We also know, and it's been another topic of my research for the last 10 years, that high doses of opioids we use during the surgery might lead to what we call opioid-induced hypersensitivity. So both of them, nociceptive inputs and also high doses of opioids, might lead to high level of sensitization and risk of developing PPSP. For many years we knew that neurons, this is the first neuron and the second neuron, we knew that the sensitization processes takes place between the first and the second neuron at the spine level mostly. And for the last 5-10 years, a lot of researchers, and I'm part of these researchers, we looked also at the glia around the nerves, and we know that all the glial cells can affect the sensitization processes. This leads to the risk of developing chronic pain. 2000, 2006, 2015, many reviews on postoperative chronic pain led to the same conclusion. It's about 5 to 10% of our patients, which means millions of patients each year, that might develop chronic pain after surgery. So we are facing a huge problem. The question of today is, why should we monitor pain? And as Dr. Sessler said, if we give too much opioids or if we give too low opioids, we will face the same problem. The answer to the question is we need to monitor pain during the surgery because if we give too low analgesia, we will have this kind of sensitization that takes place in the central nervous system. If we give too high analgesia, we will face the same problem. Very high doses of opioids will induce OIH. So we need to use something that is going to help us to guide the analgesia during the surgery. We did one study. We did several studies in Montreal, but the last one that is going to be presented today at the ESA at noon as an abstract is about the validation of the last version of the PMD, the monitor that Medasense is proposing. It's the PMD 200, the last version that we are using. And we evaluated this version and the NOL index in patients who are undergoing laparotomies with intraepidural epidural analgesia. This is the design of the study. So we start, it's the timeline here, we start on the left. Patient come into the OR, they got an epidural catheter, but we don't load the epidural catheter at that time. Then we do the general anesthesia, intubation, we monitor the NOL response to intubation. The level of remifentanil is decreased after intubation to a very low level. It's mics per kilo per minute, so it was 0.05 after a bolus of 1 mic before the intubation. 3 minutes, we perform the intubation. We have like 0.005 of remifentanil, which is almost nothing, as remifentanil infusion, running for several minutes. We prepare the patient, and then we do electrical stimulation, as Dr. Sessler was describing in the studio of Ruti. And we have like stimulation number 1, stimulation number 2, 3, and 4. The difference between these stimulation is the dosage of remifentanil we used at the time of the stimulation. Stimulation 1 and 2, it was almost no remifentanil on board. The difference is it was before the epidural loading and after the epidural loading because we wanted to assess whether or not the epidural loading would change something It's a laparotomy. It's an epidural that is placed at the thoracic level. So we wanted to know if the epidural placed at the thoracic level might change the response of the index. So before epidural, after epidural loading, same electrical standardized stimulation, tetanic stimulation. And then number 3 is done as at 0.05 of remifentanil, and then we double the concentration, 0.1 mics per kilo per minute of remifentanil. Same stimulation each time. If we look at the clinical stimuli, intubation in blue, incision in yellow, as Dr. Sessler showed in the previous study, we got exactly the same kind of answer. Intubation was done 3 minutes after 1 mics per kilo as a bolus, an IV bolus of remifentanil, and then the infusion was kept at 0.05 of remifentanil. GA induction, 3 minutes, we wait 3 minutes, perform at T0 the intubation, and that's the null response. Same thing that was described in previous papers. Incision is less reactive because we have an epidural loaded at that time. So we do a laparotomy, but we are not expecting to see the null changing much because the epidural is already working. So we see a little bit of a change, but not too much because we are making an incision on the abdomen, which is numb by the epidural analgesia. Now, if we look at the experimental stimuli that we applied, these standardized electrical stimuli, which is not operator dependent, it's always the same stimulus. You push on the button, sends an electrical stimulation. T0 at the time of the stimulation starts, and that's blue and orange curves, very low concentration of remifentanil, 0.005. You can see a nice change in the null, and it lasts for 2-3 minutes, and then it goes down to previous values. At that time, it's during surgery, but we stop the surgeons. We say before the stimulation and after the stimulation for 5 minutes, we say to the surgeons, stop the stimulation. We don't want to have interferences coming from the surgery, so they stop the surgery for a short while. And then they resume the surgery here. So before and after the epidural loading, you can see that there is no difference in terms of tetanic stimulation response, and you have the same quality of response of the null. The epidural did not affect, even if it's a thoracic epidural, it did not affect the response of the null. If you look at this one, it's the group at 0.05, so it's 10 times more than this one. So you still have a little bit of increase of the null index, but it decreases significantly compared to the response we got at almost nothing in remifentanil. The last one, 0.1, you see that we blunted the response of the null because we doubled the concentration of remifentanil. So there is a nice correlation between the null response and the dose of remifentanil we are using. To go back to the type of presentation that Dr. Sessler was using in his article with Dr. Edry, we presented the same way. Null index on that line, heart rate, mean arterial blood pressure, BIS index. And that's different concentration of remifentanil. If we look at the experimental stimuli at different concentration again, it's pre versus post stimulus. If you look at the null index, at low concentration, you have a nice change in the null. And these are the values of the null taken 3 minutes after the surgery. It's an average of the null over 3 minutes. It's not the peak of the null. So even if we average the response of the null for 3 minutes, we still have a nice response. When we increase the dosage of remifentanil, you see that we blunt slowly the response of the null. If we look at heart rate and mean arterial blood pressure, we still have good changes also, and then no more changes here. If we look at the BIS index, it doesn't change at all, so don't use the BIS index to guide your analgesia because it's not going to work. And when we build this ROG curve, same result as the previous study, published by Dr. Sessler and Dr. Edry, and same results as the study that Dr. Dan will talk about. We have a much higher sensitivity and much higher specificity than the other parameters here that are heart rate, blood pressure, BIS index. All of them, they are not super bad indexes, but as you can see, compared to the null, the sensitivity and the specificity are much lower. So in real life analgesia, in real life anesthesia, we can use the null, and the null has some utility. We are going to talk about one clinical case It's a woman, 72 kilos, 160 centimeters, 50 years old. She has no real history. She has a little bit of hypertension that is controlled under treatment. And she goes laparoscopy for cholecystectomy. She had an intubation, and this is what you can see on the NOL index. So before the intubation was performed, you can see the NOL is low. It's between 10, 15, whatever. And then at the time of intubation, this is 1 minute, 2 minutes, 3 minutes, 5 minutes, so you have the timeline here. At the time of intubation, you can see a change, as we saw in the study that we have done, or the study that Dr. Sessler has done also. So you can see a nice change, and this is what you see in the real life. Increase up to, in this case, it doesn't go so high because it was under remifentanil analgesia, but still it does change a little bit, and it takes like 1 minute or 2 minutes to go down to normal values. In these slides, you have like the screen of the NOL that you will have on your monitor. That's the Draeger ventilator we have in Montreal, and that's the Draeger monitor we have in Montreal. So incision, first trocar, insufflation, 3 stimulus that are kind of painful within 1 minute. And after these 3 stimuli, you can see the increase of the NOL, reaching a plateau of 50. And then here, because it lasted a little bit more than 1 minute, I said, oh, I need to do something. I'm not going to leave my patient this way. So I gave a bolus of remifentanil, an extra bolus of remifentanil of 0.3 mics per kilo, about 21 microgram in this patient. And you can slowly see that it was going down, but then they did another stimulus here, which is the insertion of the second trocar with the second incision and second trocar insertion. And at the second trocar insertion, you can see that it goes up again, and then it will go down slowly. If we look at that point, 5 minutes here, you have a high blood pressure, no tachycardia, but a little bit higher than what it was. The BIS is stable, and the MAC is 0.8. If we go a few minutes later, this was 8:37, 8:38. You have the same thing that you can see the same thing, and now we injected the bolus here, the extra bolus of remifentanil, 1 minute, 2 minutes, no more incision or stimulation. It goes slowly down because my remifentanil is kicking in slowly. And then it's 8:42, 3 minutes after this one. You can see that it goes down, and it stays low because my remifentanil was increased and my bolus of remifentanil is working now. So from that, I can say that my NOL index helped me in assessing the analgesic effect of my opioid and the doses that I gave. The NOL index also can help me in making a decision in the OR, making a decision on whether I should give opioids or whether I should give something else. And I'm going to explain why I'm talking about something else. Few minutes after that, so it was at very low doses, very low values of NOL. You see 1, so it's a very, very low value for the NOL, meaning that there is no nociception on board. The patient doesn't feel any nociception. The MAC is still at 0.8, the BIS is TD 55, and we have a blood pressure that keeps high. And we said we don't want to, if I didn't have my NOL values, with this kind of blood pressure, I would say, what shall I do? Shall I give opioids to decrease my blood pressure? Perhaps the patient feels pain, and I need to do something. But in fact, because I have my NOL value, I see that the NOL value is nothing, very low, so I don't need to give opioids. So my choice here was to say, instead of giving opioids, to decrease the blood pressure, I'm going to use a calcium channel blocker, the diltiazem, and the diltiazem was injected here, and you can see that few minutes, so it's 8:42, 8:45, about 8:45, the blood pressure starts coming down, and my NOL value is still down. So it helps me to make my decision in terms of what I should give during the anesthesia. Other things, it's a laparoscopy. Most of the time we think that laparoscopy is not painful, but with this kind of tool, you can really see that some things during the surgery are painful. Pulling on the gallbladder, burning the gallbladder, all these things that, sometimes they really pull strongly on the gallbladder. And when you pull too much on the gallbladder, then you can see your index increasing again. So it was 845 here, 846. You can see the increase slowly, it increases, but it didn't last very long. It went above 25, my threshold of 25, which to me means nociception and pain, and I need to do something. So for 30 seconds, it was a little bit above, but then they removed the pulling, they stopped pulling and burning, and then it went down slowly, so I said, no need to give something. I'm not going to give something because it's calming down and it's going down slowly, so I'm not going to inject anything. It's another case, another patient, but for the same kind of laparoscopic cholecystectomy. Again, in that case, it's a little bit different because the NOL index went high, above 25, stayed high. I didn't give anything here because it was slowly going down, but then I saw them pulling and trying to burn and pulling hard on the gallbladder, and it went up again and up and up and up, and I said, okay, let's give fentanyl. This one was not under remifentanil, it was made with fentanyl. And so we gave a bolus of fentanyl here, just to decrease the value of the NOL and to give a better analgesia. The bolus was given here, and it took like 1-2 minutes, and then it decreased to less than 25 as a NOL. So it helps me also to identify when I need to give opioids. If it lasts longer than 30 seconds or 1 minute, I would give something. If it goes down, I don't give anything. So based on this, we can make some algorithm. Oops. That's fine. So let's look at, this is not really interesting, it's just the preparation of the patient in the OR, and then we adjust the administration of the hypnotic based on the BIS index. You say, okay, I want my BIS to be between 40 and 60, as we were taught to do, and then we want to adjust the NOL index based on the value of the NOL. So if my NOL index is above 25 for more than 1 minute, this is my decision to say, I'm going to give a bolus of opioids, and or I'm going to increase the infusion of remifentanil if I do remifentanil. If I don't do remifentanil as an infusion, but if I use fentanyl or any other opioids, I would give a bolus of the opioids. And then I wait 3-5 minutes, and again, if I see something going down, then I don't give another bolus. If I see that the NOL stays very high, I would give another bolus until my NOL value goes down. So it's like a loop with the NOL index. Above 25, I give a bolus. If it goes below 10, it's a little bit too much of analgesia, so I will decrease my infusion, or I will stop giving boluses of analgesics. And again, the same loop here. If it's too low, then I will try to decrease my analgesia, and I will try to titrate my analgesia better. Future directions, we try in Montreal, so I know that cinnamon is not spelled this way, but it's an acronym for the title that we have, of the study that we are doing in Montreal right now. We are looking at the utility of the association of the BIS plus the NOL to guide anesthesia on one hand and analgesia on the other hand in order to have or to improve the outcome of the patient, at least in the early period at the end of the surgery and in the PACU and for 2-3 days after the surgery. One group is monitored, so they have the BIS and the NOL index to guide both anesthesia and analgesia. And one group is managed classically, no BIS, no NOL, and the management of anesthesia is based on the MAC value, and the management of analgesia is based on the variation of the blood pressure. And we have different outcomes that we are looking at: the time for awakening, time for extubation, time in PACU, rehabilitation in PACU, quality of rehabilitation in PACU, pain scores in PACU, opioid consumption in PACU, and for the 2 days after the surgery. And we watch the patient for 5 days, and then we again call them at 3 months and 6 months after the surgery. So it's a going on study. We hope that we will make some changes. Not sure that with this pilot study we will make changes on the long-term outcomes, but at least we will get preliminary data that might be interesting, and we want to see if we can make at least very nice changes for the PACU time and for the 2 days after the surgery. So at the conclusion, introducing a novel nociception index in common practice is challenging. The pain during the surgery remains a real challenge for us. We, as Dr. Sessler was saying, we don't really know, if we don't use these indexes, we don't really know how to guide our anesthesia. Sometimes we try to guess, and sometimes we make mistake by guessing. So by using these devices, we try not to make these mistakes that we were making before. As I said, too low analgesia, too high analgesia might lead to the same consequence, which is sensitization of the central nervous system and risk of developing chronic pain. Among the available devices on the market, the NOL has been validated with rigorous studies. 2 studies were published in Anesthesiology in December 2015 and June 2016, so it's a high level of publication. The study that we have done is going to be submitted to Anesthesiology also very soon. So it's rigorous studies, multiparametric approach with very high sensitivity and specificity. And the future also is to look at whether or not we can change the quality of the anesthesia and the analgesia in order to improve the outcome of the patient. Thank you.